Us for our virtual presentation today. The title of our talk is Determining Outcomes of Phalloplasty and Metoidioplasty, a community-directed way forward. My name is Leo Rutherford. I'm a PhD candidate at the University of Victoria in British Columbia, Canada, and I'm joined today by Aeron Stark, who is a research assistant at the University of Victoria. Our co-authors for this presentation and in general for our project are listed down here in alphabetical order. And you'll hear a little bit more about them and their involvement later on in the talk. Also, thank you to my...
We have a request from interpreters to slow it down. So if you click the little gear settings button on the page and then playback speed, you can put it on like 0.75 would be great.
Boy, this setting's great. Whoops, I didn't mean to do that though. Hold on. All right, let's try that again. Do you want me to start from the beginning again?
I think it should be fine. It was mostly an introduction and we can see that.
Research supervisors who are not mentioned here, Nathan Lachowski and Aaron DeVore of University of Victoria and Aidan Scheim from Drexel University. We are very thankful to our sponsors and partners for this research project, which include the Canadian Institute for Health Research, the Strategy for Patient-Oriented Research, the BC Support Unit, University of Victoria, Community-Based Research Centre in Vancouver, and Transcare BC. This is an overview of our presentation today. Aeron will be giving an introduction of what phalloplasty and metoidioplasty are, and then some background information about how currently outcomes are determined in academic and medical literature. Then it'll pass back over to me, and I will talk to you about our project, what we're working on, and how what we're doing is different from the current research on this topic. And lastly, I'll share some future direction, some thought about our knowledge translation products, and how we hope our research will help the community. I will pass it over to Aeron now. Aeron, just let me know when I should advance the slides.
Just going to talk quickly about what phalloplasty and metoidioplasty are. So phalloplasty and metoidioplasty are two related but distinct surgeries, and they're used as gender-affirming surgeries for trans men and non-binary people. They each have strengths, drawbacks, limitations, and complications, and they can co-occur with several additional surgeries, either during the first instance of genital surgery or at later times, depending on surgeon preference and patient desire. So I'm going to go into more detail about each procedure on the next few slides, and I will be using some anatomical terms. So phalloplasty has been described as a modular set of procedures that can be combined, mixed, and matched to meet the needs of each individual patient due to the numerous options of additional surgeries. They can be conducted in several different ways with numerous variations occurring over time and geographic region. And they can be combined with vaginectomy, which is the removal of vagina and cervix and closure of vaginal opening. Scrotoplasty, which is the creation of scrotum using labia majora, which also may include testicular implants, urethral lengthening, and erectile implant. Multiple options for graft sites include thigh, arm, abdomen, and back. Next slide. Metoidioplasty, or what's commonly called meta, was specifically created for trans men, and it utilizes the increased size of the clitoris that is enlarged due to testosterone. The clitoral ligaments are released, and labial tissue is used to bulk up the neophallus. The urethra can be extended beyond its position into the newly lengthened penis, which is called urethral lengthening. There's no donor site, so there's no scarring. The recovery is shorter, and there's usually less complications for that procedure. I'm going to go a bit of background about how current outcomes are determined in the literature. Surgical outcomes are characteristics that change as a result of surgical intervention. And surgeons are traditionally the determiners of what a successful surgical outcome is. And phalloplasty and metoidioplasty are often benchmarked by a set of ideal results. And results are deemed successful if there's a satisfactory appearance, the ability to urinate, able to have penetrative sex, and if there's erotic and tactile sensation. And outcomes are currently measured using clinical exams, interviews, and questionnaires. Clinical exams most commonly reported were sexual function, complication rates, and satisfaction with aesthetic results. Among studies that use interviews with clinical exams, complications, aesthetic satisfaction, and erogenous sensation were most commonly used to determine results. In questionnaires, it was mental health and body image, and also psychosocial aspects such as quality of life, surgical satisfaction, and social support. Anxiety and depression were the most common aspects of mental health reported in questionnaires, and dysphoria was the most commonly included aspect of body image. There are a few limitations of current literature. The overall sample sizes are very small. Most are on average 24 patients. They utilize convenient sampling, which is useful for ease of collecting data, but this type of sampling does not generate data that can represent a whole population. Rather, the data only speaks to outcomes of participants. There's single instances of data collection, and no patients are usually consulted in what outcomes should be measured. And most of the data collected via clinical exams are already part of follow-up and routine medical reporting, such as complication rates, needs for surgeries, scar care. There's not very many questions about mental health and body image. Thank you.
Thanks so much, Aeron. I'm excited to talk to you all now about our project. The title of our research project is Progress for Metoidioplasty and Phalloplasty. Progress is an acronym that stands for Patient-Reported Outcomes of Genital Reconstruction and Experiences of Surgical Satisfaction. The logo that you see here is a work in progress, pun intended, but I'll be working with a graphic designer to change that up soon. To sum up the goal for our project, we're seeking to make change both in the academic and medical literature about phalloplasty and metoidioplasty, and more importantly, give patients more information about what to expect if they're going to have phalloplasty and metoidioplasty, including what the recovery and preparation process is like. Other than my research supervisors, who I briefly mentioned at the beginning of this call, the rest of our team of 8 is made up of individuals with lived experience of either phalloplasty and or metoidioplasty. So we are making decisions together based on personal experience and knowledge that we have and information that's been shared with us by other community members. We come from across Canada and the United States, and we have experiences with different surgical teams and other different experiences of life. We are hopeful to recruit 300 participants from across the world to participate in a survey that we are currently developing and soon will be out. While other research projects are consulting or including a few former patients, this project is designed by and for those of us with lived experience of surgery. Surgeons have conducted research about outcomes that are important to them, but there's much more to consider than complications and other items that are currently discussed in academic literature, as Aeron mentioned. So our survey is including a number of topics that we've identified as important and lacking in current literature. And these are a few examples on the screen. So patient preparedness for surgery includes what people do to get ready for surgery and how they feel going into it, including the informed consent process and what their process of surgical readiness evaluations look like and whether or not that's useful or helpful in preparing them, as well as what kind of knowledge people have about surgery going into it. Doctor-patient relationships are also something that's not mentioned often in the current literature, and we think that relationships with surgeons and surgical teams might in some way impact patient experiences. Postoperative depression is also not mentioned very often in academic literature, and something that we've noticed is important to discuss as part of the both preparation for surgery and in general after surgery. So here's a little bit about our process. So if you're wondering where's our research project at now, we are currently developing the survey that we're going to be using as a data collection tool. After a number of meetings, we have decided on some topic areas to include, which include the items that I mentioned before and an additional few as well. We're still designing some survey questions, and we're making decisions currently by simple majority vote. Likely late in the fall, we will launch our survey. As I said, it will be available internationally. It'll be in English and possibly translated into French. Our data analysis and interpretation will highlight aspects of preparing for, undergoing, and recovering from surgery that might impact well-being. And it will highlight whether certain groups of people experience poor outcomes of surgical care, poor relationships with surgeons, and other health outcomes. Our knowledge translation activities will focus first and foremost on items that are important for community members. While we haven't decided quite yet exactly what knowledge translation activities will occur, I'm quite confident that we will at least have community reports, infographics, social media content, and I'm hopeful for a simple data dashboard where people can conduct simple statistical analyses to look at whatever outcomes they're interested in our data. This project is just the beginning for me, as it's part of my dissertation. I plan, after completion of my PhD, to continue work in this area to address the lack of trans-led and trans-created research on these topic areas and the lack of holistic outcome measures for phalloplasty and metoidioplasty. It's our hope as a group that future research on transition-related surgeries uses similar robust community inclusion to ensure that research is meaningful and appropriate to our community. I'm sad that we couldn't be in person or even live with you all today, but you can check out more on our website soon. It's currently in development, and here's a little snippet on the side of what you'll see when you visit our website. But stay tuned there for some bios from our team, some information about why the research is important to us, and photos. You can check that out when you get a chance. Thank you so much for attending our talk, and thank you to the organizers for creating this space to highlight trans-led research that is important to us. Feel free to reach out to me via email, my personal UVic email there, or the study email, the progressstudy@gmail.com. I'm sorry I couldn't answer your questions live. I hope you enjoy the rest of the conference.
To unmute myself. Thank you, Leo, for that great presentation. I really hope you will take a look at the research. It's shaping up to be a really good project, and very community-centric. So next we go to finding safety, implications for clinical work with transgender and non-binary youth and their families from a qualitative study of the 2016 to 2018 U.S. political climate with Jessica Kant. Jessica Kant is a licensed independent clinical social worker and part-time lecturer at Boston University, whose training and work with transgender adolescents provides firsthand insight into the unique stressors facing this population. Jessica is currently the lead analyst of the Trans Family Election Study at Boston Children's Hospital. As a family therapist, her clinical focus is on bringing the socio-political frame into therapeutic discussions, with an emphasis on family systems. As a trans woman, she draws upon not only her expertise as a clinician and researcher, but also her lived experience in her analysis of social forces impacting transgender and non-binary youth.
Thanks so much, Noah. Before I start, I pasted into the chat a link tree, which an idea I stole from somebody else earlier in the conference. These will have the links that I'm going to reference so that I don't have to keep pointing out the QR codes and things like that. So feel free to check those out and follow along. There are also some handouts based on what we sort of call practice-based wisdom these are often tips that I would give my students when working with families where there is discord. So today I'm going to be talking about the clinical implications of a qualitative study. As Noah said, it is with non-binary youth and their families from the 2016-2018 US political climate. One thing that's worth saying, just to remind those of you that are outside of the US, that the 2016 election, we all probably remember, was the election of Donald Trump. 2018 was the gubernatorial election, during which there were a lot of ballot referendums, particularly around bathroom access. And this was something that came up over and over in the interviews. So this secondary analysis, which was part of the larger Trans Teens and Family Narratives project, which took place between 2015 and 2019, was looking at the effects of the sociopolitical climate. And this was looking at it from family systems theory, which for those who are unfamiliar, there's a primer in the link tree, but it is essentially the sort of governing body of knowledge that undergirds modern family therapy. And it looks at families as a whole, and is taken from general systems theory for any biologists who are watching. The resulting data set was 20 families, an N of 60 with 20 trans non-binary youth, 11 siblings, and 29 caregivers. The codebook was originally deductively generated from our interview prompts. After we established iterator reliability, we, between myself and David Pletta, the other coder, we grouped these into clusters, which you can see on the side. Preliminary themes were generated using immersion crystallization and thematic analysis. And we took multiple recursive passes. This was through, I want to say it was at least 1,000 pages of single-space pages of interviews. And so we refined them into themes and sub-themes with myself, David Pletta, and our PI, Sabra Katzweiss. This is one of the code clusters, sort of, or our theoretical framework as it evolved. And you can see a poster explaining more in detail about how that worked if you scan the QR code or go to the link tree. And that's the last I'm going to say about that. So some of the changes that we observed, when we were looking at discord in families, what we found was that there was a pretty massive redrawing of boundaries. And so that meant that, let's say there was an extended family member who was severely was very conservative. We found that there might be sort of a rallying around the family line, around the boundary, in which that person got cut off from communication. And this was done to shield the trans non-binary youth. There was also what we'd say is member exclusion, although what I want to say is that this was really that the climate amplified pre-existing rifts in family systems. And so they were there before, and the tension of the climate really drew these things to a head. And lastly, from the structural family therapy literature, you'll see that there is some formation of coalitions and alliances. Well, coalitions have a negative connotation. The alliances were often really helpful and included, say, siblings who both occupied marginalized statuses and therefore were able to join together and get each other through the election. So when there are rapid changes in family systems like we saw during the election, clinicians should be mindful of some of the things that families lose or some of the things that happen as a result. Families may lose extrafamilial support, and that particularly is salient in terms of finances and childcare. For caregivers, it limits their social supports because sometimes you see a division of friends have to redefine. And also there's less space for those caregivers to process their own feelings because the people they might rely on aren't there to talk to. I just have an example genogram. And what I would encourage for people who are working with families, particularly family therapists, is to use genograms where you also include, as I did in this example, which is actually from my notebook, interactional patterns as you see them, to sort of watch them as they shift over time. Changes in family structure were seen through language. I'm going to read two excerpts really quickly. My boyfriend is on the same page, kind of reacts the same way, but I haven't had a conversation with anyone else in my family about that. My mom supported Trump. Our family did not support Trump. We agreed to discuss the presidential election or the presidency, so that's an effect. We don't talk politics. And a different participant, different family. Basically, everyone in the household well, my father supports Trump, so not everyone in my family, but my household does not support Trump. And I'll feel the same way about his opinions towards trans rights and trans ideas. And so here you can see this is the first hint that we start to see divisions as they're visible in language, with the naming of who is family and then the naming of family members who are not included in that definition. And so some prompts that I might recommend people who are noticing this and working with children of trans youth is, I notice you distinguish between your dad and your family. Can you tell me more about that? Has it always been this way? When did that shift occur? I'm going to check the chat real quickly. This is important because kids are sensitive to changes in language. And if they perceive the disagreements to be about themselves, particularly because they are trans or non-binary, and it was some of the rhetoric during the election was around that, they're more likely to internalize blame for separation. So early dialogue with very clear messaging is important as sort of a preventative measure. There are a few frameworks that exist to address changes in family systems. My favorite is Sonja Parker's Circles of Safety. You can see this sort of bullseye, and in the center is who knows the most. This is your inner circle. As it zooms out, you start to see who knows something about this and who does not know what's going on but could be brought in. And this can be used to grow supports as other supports drop off. And by centering the who already knows, it minimizes the amount of explaining people have to do when sort of triaging, bringing in external supports. The other thing that caregivers talked about was feeling like they had to be constantly aware of misinformation and aware of new developments. So I want to say to clinicians, it is not optional to be aware of the stuff that is happening to us as trans people. And that is both for misinformation, but also for things that people are saying that are incendiary about particularly trans youth. You can't not know that and be supportive of trans people and their families. Have alternate reputable sources. And I put here, a lot of you may be familiar with Jack Turbin. One example of addressing misinformation, I believe, is his rebuttal of Abigail Schreier's nonsense. That might really be helpful because unfortunately we are seeing a lot of parents reading about so-called ROGD, and hearing from a respected physician might help counter that. Finally, there was an emotional toll taken for, say, siblings and caregivers who tried to shield trans and non-binary youth from what was happening. And so this manifested as real differences in perceptions of what was going on between participants. But privately, caregivers really talked about this taking a toll on their mental health. And in part, this was because the rhetoric was largely aimed at eroding confidence in caregivers' decisions to affirm their children's gender. And so clinicians should be prepared to sit with them in that discomfort and reify that was the right decision. And a couple of things, my theoretical home outside of systems theory as a therapist is narrative therapy, or the New Zealand and Australia schools of narrative therapy, particularly in this case, remembering the statement, sorry, I'm gonna slow down. The remembering maps and statement of position maps, where you're reconnecting caregivers to the values that they are attaching to and maybe other people who would have supported them historically in their decision. I also think group work is essential to name that it sort of gives permission when caregivers have other caregivers around saying, this was the right choice. I'm gonna stop there and just say thank you and remind you, you can see more sort of tips that I might give we don't have time for in the link tree. Thanks so much.
Great, thank you so much for that amazing presentation. Next up is Dr. Sebastian Barr. If you can just hold on for a second, I have to show that presentation. Okay. So Dr. Sebastian Barr is a psychotherapist, psychology research writer, and educator in Western Massachusetts. And they're presenting, their topic is Affirming Approaches to Working with Gender Dysphoria in Psychotherapy. Just give me a second. I will bring up that video. Okay, was sharing sound. Okay, great. And I'm just going to stop it and start it, and if you could let me know if you can hear it well.
Hello, my name is Dr. Sebastian Barr, and I'm very happy to be presenting an introduction to a project that I'm working on with.
How's that? Good, okay. And let me know if you need me to slow down the recording.
Esteemed colleagues, Drs. M. Matsuno, J. Bettergarcia, and KJ Connor. We're working on guidance for psychotherapists whose clients or patients are experiencing distress related to gender dysphoria, and guidance that specifically addresses ways that psychotherapists can facilitate relief from this gender dysphoria related stress. Some important pieces to lay out at the beginning here. We draw from our lived experiences, the stories of our communities, our clinical experiences, and our training. So we recognize that this gives us some helpful grounding, but also that our perspectives are constrained by who we are and whom we are connected to. Additionally, we want to name the very real cissexism and white supremacy that exists insidiously within the institution of psychology. We believe in the power of the side disciplines to work for liberation and healing, but recognize there are some real limits to trying to do this work while positioned within these fields. Additionally, we want to underline that we resolutely support access to gender-affirming medical care, such as hormone therapies and surgical interventions, which are evidence-based treatment for gender dysphoria and an important component to supporting the well-being of trans and non-binary people. We're going to be proposing psychotherapy approaches that may bring some relief, but these should never be stand-ins for facilitation of transition or gender-affirming medical care. First of all, let's briefly define the term gender dysphoria. We are speaking here about a psychological construct and not the diagnostic label. Cooper and colleagues conducted a phenomenological review of the literature of gender dysphoria and suggested that there are 4 categories of experience contained within the construct of gender dysphoria. The first, distress due to dissonance of assigned and experienced gender. The second, interface of assigned gender, gender identity, and society. 3, negative social consequences of gender identity, including distress due to misgendering. And 4, internal processing of trans negativity and rejection. So there's this underlying incongruence or sense of disconnection from or lack of ownership of parts of the physical self, but there are also critical social components in terms of how a person is being perceived or imagines they are being perceived in relation to their gender. And then the internalization of trans negativity and cisgender norms or ideals may contribute to distressing experiences of gender dysphoria as well. Gender dysphoria is often experienced as incredibly painful and a source of rumination. The degree to which it causes problems for folks varies, and there are some trans and non-binary people who do not endorse having these experiences. Obviously, describing the wide range of experiences of gender dysphoria is its own category of work, and we can't fully get into it. There are some excellent papers that do a more thorough job of this, which we recommend here. This PowerPoint is a handout, so please come back to this and check out these papers, many of which are authored by openly trans researchers. Okay, so why should therapists be concerned with this? Well, we know that gender dysphoria is related to overall mental health and well-being, so that's reason enough. And while often the best course of action is to facilitate gender affirmation steps like social and medical transitions, there are situations in which that alone is not going to resolve the dysphoria-related distress. So, for example, not everyone can access care due to barriers like cost and provider competence or contraindications. And some clients may not feel safe or want to pursue gender affirmation at that time, but are still experiencing gender dysphoria. There are routinely delays in accessing care or in experiencing the benefits, so wait lists, but also it can take a while to experience the effects of hormone therapies. So while effective sustaining relief may be in the future for a client, that person may be facing moderate or severe distress in the meantime. Additionally, there are situations in which some pieces of dysphoria can persist, return, or be triggered even after successful relief of a bulk of the dysphoria via gender affirmation. As a therapist who works with many trans and non-binary folks, gender dysphoria comes up routinely, but we really lack clinical guidance for how to be helpful in this area. You can Google how to cope with gender dysphoria and get community-generated lists and guides that are often really helpful. There's literally an illustrated WikiHow. But for clinicians, texts on being affirmative highlight the evidence in support of supporting transitions. But we believe therapists are uniquely positioned to aid in this even further, to have a role beyond the important one of facilitating transitions. We obviously don't have time to provide any actual training on this today, but we wanted to give a very quick overview of some of the ideas that we'll be talking about in our forthcoming paper and some subsequent trainings. First, we believe there are some overarching principles that need to be adhered to in order to have a solid foundation from which to address gender dysphoria. An affirmative stance, so clinicians who are not affirming of their client's gender identity, expression, related needs, and autonomy are just not going to be effective partners in this work. Additionally, research has demonstrated that non-affirmation and trans negativity can operate as insidious trauma, and the trans community has high rates of exposure to more traditionally defined traumas as well, like assault. Being mindful of how a client's presentation and needs may be affected by trauma will be critical, especially as reflection on gender dysphoria could easily be triggering. Finally, clients' experiences of and needs around gender dysphoria and identity will be shaped by their intersecting experiences and sociocultural context. So clinicians must be mindful of their client's whole self in this work. There will be no uniform model and no prototypic client. In terms of interventions for gender dysphoria relief, one set of interventions revolves around establishing understanding of the client's gender dysphoria. Dysphoria experiences are going to be idiosyncratic. So as a clinician, careful listening and exploration will serve in part as assessment and will be vital to conceptualizing the experiences and needs of each individual. But we also argue that conceptualizing that this exploration is helpful in its own right for the client as a way of promoting a more mindful relationship with their dysphoria and identifying triggers. This is also consistent with insight-oriented models of psychotherapy. For example, Austin and colleagues briefly recommend the use of narrative and emotions-focused interventions that help clients utilize metaphor and or creative nonverbal expression of experiences and emotions to increase self-understanding. This suggestion follows their finding that participants in their qualitative study often spontaneously used metaphor to illustrate their painful experiences related to gender. There are important relational interventions possible in psychotherapy when the therapist works as an affirming mirror through which a client can experience being seen by another in alignment with how they see themselves. There are ways that this happens both implicitly and explicitly. For some clients, therapy may be the first place where they get to hear new pronouns or a new name used for them. Depending on a therapist's theoretical orientation, it could be fruitful in identity development to process the client's experience of the therapist's representation of them and their gender. Cognitive interventions can help clients deconstruct harmful beliefs at the root of some dimensions of gender dysphoria, like internalized transnegativity and idealized cis norms. Further, thought patterns that can catch any of us up around anything can exacerbate the distress of gender dysphoria. For example, all or nothing thinking could amplify an experience of mild dysphoria into a protracted, moderate, or severe experience. Attending to unhelpful thought patterns, internalized transnegativity, and unrealistic cis norms is the first step to doing work to challenge those. There are different approaches for shifting these beliefs depending on theoretical orientation. One CBT-based intervention is presented in Israel and colleagues' 2018 paper and was found to be effective in reducing shame and increasing pride. Intentionally increasing exposure to celebrated body and gender diversity is also an important environmental or behavioral intervention that could shift some of these beliefs or deconstruct them. We also believe there is potential for psychotherapy to be a space that can motivate ways of relating to the body with more compassion and collaboration and connection, focusing on non-gendered relationships with the body, how bodies can be sources of pleasure, safety, and empowerment. We also see a great deal of potential for the incorporation or adaptation of somatic techniques that help clients feel safe reconnecting to their bodily experiences, though we caution this must be informed by the awareness of the potential that body-directed attention can trigger distress and lead to flooding or more dissociation. Speaking of flooding and triggering, an important element of helping clients manage gender dysphoria is building the capacity to experience and regulate distress. Sloan and Shippard have offered guidance on how to shape DBT interventions to be particularly relevant to the sources of difficult emotions that trans and non-binary people face. They note that chronic invalidation that trans folks often experience can prevent the development or use of effective emotion regulation strategies. There are other therapeutic approaches from ACT to psychodynamic work that can be incorporated to improve emotion regulation and distress tolerance. I think some might argue that this is a fundamental piece of what we do as therapists generally anyway. Last but very much not least, we propose that using psychotherapy to build sources of resilience is critical. Specifically, we highlight that work can be done inside and outside of therapy to identify what makes the client feel gender euphoric or particularly embodied. Helping a client build more of this into their lives generally is helpful, and it's also valuable to have accessible sources of gender euphoria and embodiment that clients can reach for when feeling particularly dysphoric. Other sources of resilience include broad well-being factors like sleep and physical care, and factors specific to the trans and non-binary community. We recommend incorporating Matsuno and Israel's trans resilience intervention model as a component of this work. So this was a very fast overview of elements of an ongoing project. We welcome feedback and dialogue, and we really thank you for your attention and for engaging with this, and hope you have a great rest of the conference.
Thank you so much for that amazing presentation. It's amazing. So I want to take it first to the question and answer tabs that have been brought up, because we often lose those with folks putting them in the chat. The first one up is from Theodore Davenport asking, for the fellow meta team, thanks for your presentation. I'm sorry, I will turn that off. For the fellow meta team, thanks for your presentation. Could you speak to how you are currently planning to recruit and center people of color, disabled people, and people in larger, fatter bodies whose unique experiences are often overlooked in lower surgery outcome research? Again, I think that's no, that one would be to that's a good question. 1 second.
I'm happy to speak to how that showed, like that kind of effort showed up in TransArc, but I think this was for
Leo
Rutherford's group.
Okay. I would say, because Leo couldn't be here today, if you could pass that on to him via his email. I will copy that in the chat box. We have a couple answered. Okay. Yeah, I will pass that on in the chat box so that you can ask that to Leo himself. Sorry about that. Do we have any other questions? One second.
Can I ask one?
Yeah.
I'm interested in knowing how these teams, like how these research teams got together, like the research teams that presented today, if anyone is willing to talk about that.
I'm happy to talk about the so it's been a sort of long-term process, primarily led by Dr. Giolandi and the team at Oregon Health and Sciences, going back a little bit further to sort of trying to standardize outcomes research within genital gender affirming surgery. As you know, Leo's presentation outlines, there have historically been endpoints assigned by cisgender surgeons and not necessarily capturing what matters to patients. And I think that there's growing awareness of that within the surgery community. So Dr. D and one of our other stakeholders, Dr. Amarillo, were part of a group at the American Urological Association working to kind of standardize outcomes reporting just from a does this count as a complication level, not even getting into patient-reported outcome measures. So it was sort of an iterative process where some of the earlier group recruited in more stakeholders on the steering committee, and then we had a sort of ongoing process of surveying ourselves to see what experiences were represented. There's attention to getting geographic diversity throughout the US in order to end up with, I think, what was a 17-person stakeholder steering committee before proceeding on to recruiting for the summit.
Great, thank you. Thank you for that detailed question. So I wonder if, one second.
No, there is a question. Can I speak to a question that was put on the Whova?
Yeah, absolutely. Sorry, I'm just jumping around to different platforms here trying to grab everything.
No, no worries. So something that I wanted to address was the question about changes through the pandemic. Since I work also in social epidemiology, I'm also a therapist, as my talk should hopefully illustrate. And one of the things that I've seen, one of the things I found helpful actually is as people are emerging from the pandemic, I've been relying, actually, there's a book by Alex Stitt, ECT for gender identity. And they explicate a couple of exercises for how to unpack the fears that you're experiencing when you're outside and you're experiencing, particularly the concern around overt hostility. I've personally found them helpful. I've also walked through them with some clients. I also want to say that something that I would really like to see in terms of the question around disentangling gender dysphoria from body dysmorphia. Sorry, I'm trying to slow down for the translators. There was a study, before my first grad program, I worked at Mass General under the direction of Dr. Sabina Wilhelm, who was looking at BDD. She's an expert in BDD and had written a couple of books that I think actually might show promise for more internally focused dysphoria. Certainly, the majority of dysphoria comes from living in a cis-sexist world. And I think that for that, I lean heavily on the ideas of Ignacio Martin Barro and the liberation psychology literature. But for the internally driven, there's some research that shows that the way that people who experience body dysmorphia, the way they process visual data is actually a fear response. I would direct people to Fusner out of UCLA. And so one of the things that was hypothesized, although visual tracking research is really expensive, was that over time, when we look in the mirror, we zoom in on the thing that we are most concerned about, and we start to do so at the expense of other areas. So there are things about, for example, my face that I feel dysphoria around, and I notice is the first thing I look at. And so I've actually been experimenting with mirror retraining for myself, which starts and teaching you to look at yourself differently. And I would really encourage the CBT community to really think about what might be possible for trans patients. Because certainly while the majority of dysphoria is externally bound, rooted in transphobia, it is also hard, and we internalize that, and we deserve to alleviate that suffering. Thanks for letting me jump in.
Yeah, thank you so much for that. I wonder if I could follow up with you on that and get your thoughts on working with clients towards gender affirming surgeries. So say you have a client come to you who is interested in maybe getting lower surgery, and what does that process kind of look like for you? Oh, do I have to unmute you? Sorry, Jess, I wonder if you can speak to that.
Sorry, I was saying talking offline.
Oh, sorry.
So I think it may be a different thing to talk a little bit about genitals, unless people are looking, well, actually, now that I think about it, people are likely to be looking at their genitals in the mirror. I think that's a reality for a lot of people. And so I do think that similar skills might be helpful. I also think that there are, as Gaines, I think you had mentioned, there are some protocols for examining the sort of reality testing of thoughts. And I hesitate to say that because I don't want to pathologize the experience of genital dysphoria, and also acknowledging that we do sort of internalize a critic that I think maybe we attribute more weight to because it's internally driven. And I would love to think more about how do you sort of internalize a counter critic to help people who are dealing with that while they're waiting for affirming surgeries. That's the answer that I can think of off the top of my head at this time in the morning. But I'd love to talk offline about that.
Fair. I know Francisco has a question he wants to pass on.
Oh no, I already asked mine.
Sorry, I thought you meant
I could read the one by Theodore, or you could read it because I'm recording in Spanish, so I think I'm going to mess up the recording.
Okay,
There's one by Theodore Davenport and one by
It looks like Gaines is already typing an answer.
I'm happy to also answer live.
Yeah, if you wanted to just, sorry.
Sure. So it's something that definitely the question was around discrimination on the basis of BMI and against people with larger bodies or fat people within genital gender affirming surgery. And it's something that certainly came up in the convening. I would need to check because our list of prioritized groups was long, but I don't think it was explicitly in our steering committee like self-survey as to people identifying being impacted by this issue. But it did come up in the convening and in our conversation around, access and research issues within surgery. I don't believe it made it into any of the prioritized research questions. It's something that I know, like my own research group is working on, like more nuanced views around BMI. There's a poster in the poster session of TPATH on BMI and evidence-based advocacy that I was, honored to be able to help with. So unfortunately, not much in the report from TPATH around this issue, or TransArc around this issue, but certainly interested in connecting to people working on this issue.
Great, thank you for that. And Giolani is leaving a note in the chat. BMI barriers came up as a prioritized topic in TransArc, but within the top 26 topics, not the top 8 topics from the survey. And yes, we will be hopefully tweeting out about the poster on BMI, but it is in the poster sessions panel. I wonder if, just on an offhand basis, if you have a general sense of what BMI requirements are from generally in the, if somebody, how do I put this? So it's been my experience in talking with people looking for surgery that there's widely disparate BMI requirements, and it's hard to figure out, whether a surgeon actually, are they saying that? Do they mean that? Do they have flexibility around that? And I wonder if you have any thoughts about that.
I mean, I can only speak to sort of the US context. I know that it absolutely differs in other health systems, but here it's certainly not standardized. I would say that, there is a number at which you'll see a drop off in surgeons who are open to performing surgery, and that number might be higher in the US than in other health systems, but I don't have like an evidence-based way to necessarily definitively say that. I think that it's certainly a conversation that is getting more airtime. There was recently a great article in, I believe it was Transgender Health. I can look for it and drop it in the chat, talking about BMI as like the evidence base behind BMI, specifically within genital gender affirming surgery. So I think it's hopefully something we'll see showing up more in the literature, and I absolutely would love to partner with other people who are interested in working on this issue more.
Thank you for that. That's really interesting. And yeah, if you could drop that article in the chat if you find it. We do have a couple questions that just came in. One from Jack, I believe for Jess. How stable do you think the 4-part definition of gender dysphoria is in the long run? If you were to conceptualize trans distress in depathologized from the ground up, what would that look like?
I'm going to confess, I actually don't remember the 4-part definition of gender dysphoria. And that's in part because it was mostly created by cis clinicians, or at times even worse, created by sexologists, which is extraordinarily dubious. I do conceptualize it from the ground up. I can't speak directly to the 4-part definition because I can't necessarily remember, but I think if we were to understand it from a depathologized lens, that it's bifurcated. One of them is based on the experience of living in a world that rejects you for how you understand yourself. The other are based on what I would say are particularly Western and largely rooted in white supremacy beauty standards, which are also pulled from the external. And those are what you internalize in terms of this doesn't meet this unattainable standard. And so I would certainly approach more of a 2-pronged approach. But I can't speak to that particular model at the moment.
Thank you for that. And Gaines is typing an answer to the next question, but I'm just going to read it out so everybody can hear it. From Theodore Davenport, it sounds like your team is doing a lot to center BIPOC people, which is amazing. And I'm sorry, I tend to favor acronyms. Black, Indigenous, people of color. Thanks for your work around that. I am also curious about how your team has or will address discrimination around BMI, fat bodies with, well, you kind of answered that, but I don't know if you have anything you want to add to that.
No, I think this is the one I answered, but I'm happy
Yeah.
to connect with Theodore or anyone else who wants to talk more about this issue. And I dropped a link to the article in the chat, and I'm also happy to send the PDF to people who have access issues.
Excellent, thank you. We are coming up against the end of this session, so I want to be mindful that we need to close the room to reopen it again, but I wonder if Gaines, you and Jess have any final thoughts?
None that are succinct.
Thank you, everyone, for all the questions.
Thank you so much. The presentations were great. And I really encourage folks to connect with Gaines and Jess on the Whova platform and on their other channels if you have any more questions. So I'm just going to close the room and we'll reopen it back up and go into the next session. See y'all soon.